Welcome everybody to the Sports Medicine Research Rundown podcast, and I'm your host Tim Tyler with my co-host Rob Shapiro and Donis. Today we have a special guest from Lenox Hill Hospital and Northwell Health, Dr. Greg Galano. Dr. Galano went to graduate school at Johns Hopkins, and he did his medical school and residency at Columbia Presbyterian and was one of the distinguished sports medicine fellows at the hospital for special surgery. Welcome, Dr. Galano.
Thanks. Thank you for having me. It's a pleasure.
Dr. Galano and I co-chair some committees and some programming for the ISHA, the International Society for Hip Preservation. And we're going to be having a meeting at Lenox Hill Hospital in this fall on the athletic hip. So I invite everybody to come join us there and learn more about hips. But tell us about your experience with hips, Doc.
So, I had some exposure to it in training, but it was definitely an evolving field. And in my time in practice, it's definitely changed a lot since what I learned, 10 or 15 years ago. And I think it's, in the subspecialty of sports medicine, it's definitely the most rapidly evolving part of sports medicine. And I think, it's definitely got the biggest potential for further research. I think there's a lot of things out there that are, kind of unknown or based on, no real clinical evidence that I think those are really, me personally, those are my focuses in practice, I would say, because, obviously with anything in sports medicine, it's all about, getting the patient better, return to sport, return to sport rate, return to sport time. And that's something that we can really, I think, refine a lot better in hip preservation, hip arthroscopy, the treatment of the athletic hip injury. Those are all things that, I think there's still room for tremendous growth in those areas.
Excellent. And when I started in the 90s, nobody was even operating on hips. People were not stopping playing because they had interarticular hip pain. This kind of evolved as my career went on and the years went by. Is it an age-related thing? Is it a sport-related thing? What predisposes somebody to having labral pathology, which we'll talk about in this article tonight?
So I always talk to patients about, labral tears and hip impingement. There's two components. There's basically the anatomic component, and then there's the environment component. So part of it is, what you were predisposed to and what the shape of your hip looks like. And then the other is, what kind of stress do you apply to your hip? And obviously, certain activities, high impact activities, for instance, or high flexion activities or rotational activities, those are really the things that are going to stress the actual femoroacetabular joint the most. And even beyond that, we see a lot of, extra articular, quote unquote, hip problems. And so there's a gray area. It's not all one or the other. There's definitely a continuum, and that even would extend to, the lower back, the sacroiliac joints. There are a lot of things that encompass athletic hip injuries that even beyond the hip itself, there's a lot of involvement of surrounding areas.
Would you say that one particular sport or a couple of sports are predisposing factors to getting hip labral tears or hip impingement?
Yeah, so the number one sport for me is adolescent hockey. So, similar to how we know that the adolescent shoulder thrower has implications, the adolescent skater, particularly, the way that I always talk about impingement is this is generally the shape of your hip was determined when you were a teenager, right? And so that's when the growth plates in your hip closed, and that determined the overall shape configuration of or geography of your hip joint. And as we know in the shoulder, certain forces or certain torque applied to a joint can actually affect the anatomy. And I think there's starting to be evidence to show that that is true in the hip as well. We know that in the shoulder, we know that you get, more external rotation, more, retroversion, retrotorsion. These are all things that we know from the shoulder, and it's a continuum in the hip as well. Other sports that are very common to be affected, American football, rugby, soccer, um, and baseball to some degree, golf. A lot of the torsional sports, I would say, are highly impacted.
And is it kind of a trauma thing, or is it an insidious onset? Is it from repetitive trauma, as you just alluded to, or do you get traumas and get these labral tears like a shoulder with a traumatic activity? What have you seen in your practice, doctor?
So I've definitely seen it all. I've seen patients with, acute labral tears. I've seen even teenagers with actual hip dislocations or hip subluxations. So, those would be more on the spectrum of acute traumatic. But I would say probably the more common is the micro trauma. So, I saw 2 or 3 patients in the office today that have had symptoms for, five plus years, particularly when you're seeing a lot of patients that were, you know, the more common patient obviously is the former athlete. So somebody who's in their, late 20s, early 30s, they played college sports, they had some issues, they were told maybe in the past they had a hip flexor strain or a groin pull, and they were just wrote off as inflexible in their hips when their underlying pathology was probably all along they had femoroacetabular impingement. And so that's the most common that I see. And to piggyback on that, the most common patient that I see is somebody who has kind of been around the block in terms of treatment, in terms of diagnosis. I see patients with that present with a herniated lumbar disc, somebody that presents with medial knee pain, somebody that presents with genital pain that's been worked up by a urologist. I mean, there's plenty of what we often consider in this type of demographic, like quote unquote atypical hip pain, and a lot of that we can parse out because now we have better imaging, we have better capability to assess the patient in the office, better physical exam findings, and a lot of times we will do a diagnostic and or therapeutic injection because even if your pain is buttock pain or sacroiliac joint pain or even lumbar pain or even genital pain, and I inject your hip and you at least have temporary relief, I can put most of my money on your hip being the source of that pain. And you'd be very surprised in the amount of patients that I see in the office. We inject their hip, and they have asymmetric hip flexion, asymmetric internal rotation, and within 30 seconds of the injection, all of a sudden it's back to what the other. If it's an asymptomatic side, it's back to what the asymptomatic side is.
But wouldn't there be? I mean, you taught me about the bony block there with the patient in supine and bringing their leg up. So that's not going to affect that, is it, or will it?
It it won't affect that, but the other thing to keep in the back of your mind is 75 to 80% of patients that have impingement radiographic impingement findings. So they
Hmm.
have, what we call like a cam lesion or they have a pincer lesion. They have a 75 to 80% chance of having the same thing on the other side. So generally, one side, maybe they're one leg dominant, maybe it's their front leg and they're a baseball player and they're torquing through that leg as they swing. There's usually something that sets one side off versus the other side. But overall, probably if we looked critically at it and we took x-rays and we took a CAT scan and MRI, it wouldn't be that that dissimilar side to side.
Okay. And we talked a little bit about your diagnostic algorithm a little bit with the injection. Do you start off with plain X-rays and then go to MRI? Do you ever get an arthrogram, or you go right to the injection to rule out stuff? How do
So
you? Yep, go ahead.
so my basis is always to start with X-rays, and a lot of times people say, why do I need X-rays? I'm 25 years old. Probably even more important than the shoulder or the knee X-ray is the hip X-ray, because the hip X-ray, even in a young patient, tells us a tremendous amount. And so even in just, I typically do an AP pelvis and a Dunn view, which is essentially, a femoral neck profile view to see if they have a cam lesion.
Hmm.
Um, and even just those couple views, you get a tremendous amount of information just based off of that. Even if it's a teenager, you get a good amount of information. Whereas, a normal shoulder X-ray, that's not really gonna, you know, complete the pathologic review. So the X-ray is always my basis. The next step, it really depends on the severity and the amount of time that they've had symptoms. But
Okay.
anybody who's had symptoms, I would say probably 6 weeks or beyond, and or had some prior treatment, and I have a suspicion for a labral tear, I'm going to get an MR arthrogram on that patient. I think in the,
What is your like sort of keynote signs, if you will, or clinical pearls of what you're thinking? Oh, he has we see we see the cam lesion on the X-ray, but I'm thinking this patient might have a labral tear also. What are you looking for? What are you looking to hear to say? Oh, let's get our MRI right away.
so the most important thing I do is I put the patient supine on the table.
Okay.
And again, if they have an asymptomatic side and a symptomatic side, it's pretty easy for me, because the first thing I do is I convince not that I need to convince them, but I show the patient that they have asymmetric hip flexion on the affected side versus the non-affected side. And it's very easy to do that, because you can, lean on their legs, and I'll say I'm putting a significant amount of weight, of my body weight, on your legs. Two signs. One is reduced hip flexion. The
Okay.
second sign is they feel pinchiness in the groin, anteriorly or laterally, on the affected side, which they don't feel on the other side. I think those two things, for me at least, those are the most convincing things for me. Obviously, then we move on to things like the fadir, flexion, adduction, internal rotation. Um, Again, so a lot of patients, even if they're asymptomatic on the contralateral on the opposite side, they will have, compared to a mean, um, of non-impingement patients, they will have decreased internal rotation. They will have somewhat decreased flexion, but those are really, I would say, the decreased flexion, the pinchy sensation on the affected side, and then the positive impingement sign. Essentially, those are, for me, in terms of intra-articular pathology, those are probably the most important things.
Okay. And will you give them a course of non-operative treatment like this article that we're reviewing tonight did, or will you go straight to surgery? What's your thought on that?
So, I mean, the crazy part is sometimes we're handcuffed by insurance companies, and
Hmm.
so a lot of times I've had patients come in with 10 years of symptoms, and they've just recently gotten worse. I mean, sometimes they've even done therapy in the past, but it's been years before. I've had an insurance company cancel the surgery because they haven't had 8 weeks of supervised physical therapy in the last 6 months. um, which to me, I mean, it's very frustrating in that particular patient, because the biggest factor for me is time, right? If somebody responds to non-operative management, if it's therapy and or injection or both, and it's 6 8 weeks and they're getting significantly better, I'm never going to suggest surgery on somebody like that. But somebody who's had repetitive worsening symptoms, again, since they were in college 5 to 10 years ago, and it's just worsened over time, um, for that patient, I would be much more aggressive about suggesting surgery.
Okay.
Similar to, if I see, for instance, on an MRI that there's already starting to be significant cartilage damage, and that's independent of age. I could see a 19-year-old with significant cartilage damage already. a 6'5", football player, I'm gonna be much more forceful and aggressive about suggesting surgery for somebody like that, as opposed to, a 35-year-old with perfectly healthy cartilage and a small labral tear. I would definitely rehab them longer because, we know to some degree, impingement is somewhat of a kind of like a silent time bomb, but we don't particularly know the acceleration rate. We know, I've seen patients that got to 50 or 60 and they have minimal degenerative findings. They have a labral tear and they have a large cam lesion. And, I tell them mostly you're lucky that you made it to this point and you didn't end up with arthritis at an earlier age. That's better than the 20 to 25-year-old that has severe impingement and is already breaking down their hip. That's probably the hardest situation to deal with
Hmm.
because, I think the studies now show 10 years and beyond, if we get rid of your cam lesion, your risk of arthritis drops significantly. It's never going to be, exactly normal. Similar like an ACL patient who tears their ACL, we reconstruct their ACL. It's never going to be what somebody who didn't tear their ACL, but we can definitely slow and or halt the progression of the arthritic process by doing hip arthroscopy and a decompression. But again, if you come in with a lot of damage, I'm never going to reverse that damage. I'm never going to be able to reverse that damage.
And the good news is that Brian Scott in the Arthroplasty Journal in 2020 found no difference in the rate of conversion to a total hip for operative cases versus non-operative treatment. So, I mean, it's not there's no downside to having your hip scoped. And in fact, a BJSM article by Lassie Israel in 2021 found that prescribed physiotherapy was inferior actually to hip arthroscopy. Their outcomes were worse in the physical therapy group than the hip arthroscopy group. So there's some evidence to support doing hip arthroscopy, certainly. When you do your hip arthroscopy, do you debride the labrum? Do you repair it? Do you do a capsular repair? I know that some poor outcomes have been linked to capsular repairs. What do you do? And then we'll go on to talk about the 360s and the full and the partials and the fulls and allograft versus autograft, if you don't mind.
So I would say 95% of the intraarticular hip scopes that I do are labral repairs and or reconstructions.
Mhm.
It is pretty rare that I do a debridement, but I think there's definitely still a role for debridement. If I have a 45-year-old with, you know, early arthritic changes and a huge cam lesion and, you know, basically a very degenerative labrum, or, maybe a not repairable labrum, I think somebody like that who has a, labral flap or mechanical symptoms, I think there's definitely still a role for debridement in some of those patients. And why do we repair labrums? Why do we reconstruct labrums? The labrum in your hip is not the labrum in your shoulder. It's not a bumper, right? And we know in the hip the primary function of the labrum is a suction seal, right?
Right.
And so, for some of those patients, I think if they have a big cam lesion and you decompress their hip, they get very good relief from that. They get better range of motion than they've had for the last like 25 or 30 years as an adult. So I think a lot of those patients are very satisfied, even if they don't have a full, even if they have a partial debridement. So in some cases, you can even debride the labrum and just the chondrolabral junction, so like the lining of the socket or the configuration of the socket, you can actually still get a seal in those patients. And one thing that we always test intraoperatively during surgery is after any labral work that we do, we release the traction and we put the ball back in the socket. And
Okay.
you can actually see that suction seal. So we put it back in the socket and then I have the assistant pull light traction on it and you actually see like a pucker or pop as the ball comes out of the socket. So we know that some seal is maintained. And so I definitely think it's a limited role at this point. in terms of debridement, but there is still a role because in some of those patients, if they have not necessarily advanced, osteoarthritic changes, but mild to moderate changes, which, a lot of patients we're trying to weed out and not operate on those patients because we know they have inferior outcomes. But some of those patients, again, with just the decompression, they're very happy as a result of that. And I've
Mhm.
even done, bilaterals where, we were able to repair the labrum on one side, we had to debride the labrum on the other side. Sometimes the labral debridement side is the more, satisfied side of the two. So just because you have a labral repair, if you have a bad actor labrum, a pain generating labrum, even if I do a perfect repair on that, there's a certain percentage of patients that still have pain just because of the labrum itself. And part of the reasoning behind some of the people who really push for labral reconstruction is part of labral reconstruction is we're reconstructing the function of the labrum, but we're completely denervating. We're getting rid of all the nerve fibers that go to the labrum. So I can give you a suction cup, but I can give you a suction cup that has none of the pain fibers that your original suction cup had. And again, there's a certain amount of patients that I think their labrum is just a pain generator. We don't know for sure who that's going to be, but in those patients, they're probably better suited with a debridement and or a labral reconstruction.
Okay. When you put the labral reconstruction in there, do you typically use anchors, suture anchors, or do you use tacks? Like, what do you use to anchor the suture back to the bone in the labrum?
Yeah, so mostly in the hip, what we're using is very small anchors. Some will use all suture anchors that are just made of suture themselves. I personally use small peak, which is like innate like non-reactive plastic. Which again, we're talking about anchors that are 1 to 2 millimeters in diameter, so they're very small, and we've tried to
Mhm.
put them right at the edge of the acetabulum because we want that. We don't want to give the patient what's called a labral mustache. A labral mustache is I repair your labrum, but I pull it up so much it's not going to give you that seal. So we
Okay.
really want to, whether it's a repair or reconstruction, the whole goal is to have the labrum sit at the edge of the acetabulum because we want to put that ball back in and want to get that suction cup. That's the
Is there
whole purpose.
is there any risk to physical therapists stretching internal external hip rotation and causing sort of like a peel back mechanism like we have in the shoulder with the single row, double row rotator cuff repairs? But that's
It,
really not. You're pretty confident on the strength of your repair.
Yeah, it's pretty. I would say it's pretty unlikely
Okay.
for the actual repair to get damaged. I would say most of my very very early rehab recommendations are probably more based on the capsular repair because I know of more biomechanical evidence that your capsular repair has more of an effect in, for instance, extension and external rotation than the actual labrum does. Takes a lot of force to to damage a labrum and repetitive force. So even some early stretching, I don't have too much issue with that.
Okay. Um, Rob, do you have any questions based on the discussion now, or do you want to delve into the art research article now, Rob Shapiro?
Just a little thing as far as like how much you look at, patient's pelvic tilt, like how often you look above. When you look at the head of the femur into the pelvis per se, do you look at the pelvic position by itself? Is that meant like a cam lesion? Would you think there's an effect or?
I think there's a tremendous effect of that. So things like tilt. So we know that if we take x-rays of 100 NFL players, 100 NHL players, the overwhelming majority of them have cam lesions and they have radiographic impingement. The overwhelming majority of those patients don't have symptoms, right? So there has to be something above or below that have an effect, and the lumbar spine, the sacroiliac joint, pelvic tilt. I mean, that I to me, that's why patients with big cam lesions that have no symptoms, that's why they have no symptoms because they can tilt their pelvis in the appropriate orientation during their sporting activities that it doesn't really limit them. Obviously, we have to look at what sport are we talking about? An offensive lineman versus, a gymnast or a ballet dancer, the constraints of their hip and the obviously what they're asking of their hip in terms of range of motion, completely different. So I think it's sport specific, it's body habitus specific, and I absolutely agree that your lumbar spine, your lordosis, your tilt, all these things have a tremendous effect on FAI. I don't care about the patient that has FAI radiographically. I care about the patient that has symptomatic FAI, because again, I don't. Half these patients come in only having one side symptomatic, their other side doesn't look different, right? So what's the deal? Something is out of balance on the side that's symptomatic. That's the reasoning for us doing any treatment on it.
Thank you.
Rob, I guess you're right. Maybe the spine does matter. Maybe you're right.
Yeah, a little bit. And just a quick thing, and then I'll leave it alone. Like dysplasia versus a true cam lesion. So under coverage, over coverage, both have labral problems. Do you approach them differently, or is it just
So that's a tricky problem, and I think the problem is you could have both, right? You could have impingement and dysplasia in the same patient, right? So part of the reasoning for us to look at a lot of 3D imaging. So historically and kind of contemporarily, we use CT 3D. I get a 3D CT scan on almost every patient that I operate on for impingement, because I tell the patient it's a 3D GPS for me during the surgery, right? I'm going to take all your soft tissue off. I can take your bone, rotate it in 3D. And my job is to be like a sculptor, right? And I need to take a burr and I need to reshape your hip so that it's not going to pinch together anymore. And so you could have undercoverage. You could have undercoverage laterally, so straight over the top, or you could have undercoverage anteriorly. But you could have vice versa. You could have also a large cam lesion that's impinging. If it's a borderline dysplasia patient, meaning their center edge angle is 25 to 20, I generally treat that patient like a run of the mill impingement patient if they do have impingement, because I would say there's at least 5 to 10 studies now that show if you treat that patient like a normal impingement patient, they're going to do as well as a normal impingement patient. If it becomes a patient who has significant undercoverage, like under 20 or 15 center edge angle, I'm more likely to refer them to one of my colleagues who's an osteotomy person, because there's definitely different labral pathology that can happen. With a cam lesion, it's basically compression of that cam at the base of the labrum that's going to cause a labral base tear. Whereas if you have undercoverage and instead of having a nice roof, you have a very shallow roof, you're walking on your labrum. You're putting a lot of stress on your labrum. So the worst thing you can do is take bone off of, obviously, as we know, the worst thing you can do is take bone off of a dysplastic, because for whatever concentration of force they had on their hip, you just exponentially increase that. And so sometimes it's a delicate balance. And sometimes, again, you have to look at the patient. A lot of dancers are dysplastic. A lot of figure skaters are dysplastic. Again, I think there is some influence of, when you're 13 years old, if you're, skating for 3 hours a day, that's going to do certain things to your hip versus, if you're doing ballet for 4 hours a day or gymnastics for that, there's different forces being applied to those patients.
Do you come back from an osteotomy of the hip though to return to play and go back to the previous level of your sport? I don't know if I've seen that.
Yeah, for high level sports, I don't know that there's a lot of studies out there. For more recreational and kind of daily activity, exercise, they have reasonable outcomes. I think again the problematic part is if these patients are caught when they're teenagers, that's totally different than I've seen patients that are in their 30s and even up to like 40 years old where people are doing osteotomies on those patients. To me, I think it's at some point that's a big operation.
Yeah.
for a teenager versus a 35-year-old who has a job, and has to work. For a hip or arthroscopy patient, I have them back at the desk job, and a lot of people working from home, within days of the surgery. You have an osteotomy, that's not happening for a while, because that's a much bigger and more painful operation. And in the end, if they're ending up with a total hip in 10 years, 15 years from then, I mean, to some degree it would be more streamlined, for them to just kind of have that later on. So that's why sometimes particularly with the borderline dysplastics, we'll push the envelope in terms of doing hip arthroscopy. I'm not going to do a hip arthroscopy on somebody who has an under 15 center edge angle. That's kind of crazy. But if somebody has a 20 or 25 center edge angle, again, I think the morbidity of my surgery versus them getting an osteotomy, I think that's, we definitely have to take that into account.
I'd probably stop playing sports at that point. And that's why this is called the Sports Medicine Research Rundown, Dr. Galano. All right. Let's move on to the article now. And maybe you should introduce the article, Dr. Galano, since you were Dr. Lamba's co-fellow, right?
I was no, it was actually Aaron Critch. Aaron Critch. I was actually texting with him today. So he's one of my co-fellows. He's now actually the chairman of ortho at Mayo Clinic. But yeah, we did a lot of hip arthroscopy and hip arthroscopy research when we were fellows together. Basically this is looking at clinical outcomes, and also looking at ability to continue with sports in a selective group. So it was a young athletic group, and it's essentially long-term follow-up. Most of the patients had 10-year plus follow-up. The average was, minimum of the minimum was 8.5 years. And kind of the takeaways from this, so they looked at, the patient acceptable symptomatic state, the PASS, right? So there are established cutoffs for particularly this is, I know it's in other parts of sports medicine, but particularly in hip arthroscopy, it's really been a focus of, these are the cutoffs that, for you to say you're pretty good after the surgery. And, there are a variety of, patient reported outcome scores that, in this one, they used modified Harris hip score, hip outcome score, the hip outcome score for ADLs, and the hip outcome score for sports. And basically what they did was they looked at them prospectively, right? And they looked at them, I think, at a year, 2 years, and then like final follow-up. The final follow-up was mostly done by phone, but they had a pretty good, follow-up rate. I think it was around 75%.
73.7% follow-up.
And so they had very good, pass rates. Basically they, what Aaron, when I was texting with him, his main takeaways were, they had these good pass rates in these outcome scores at 2 years, and then they had more or less the same pass rates at 8.5 years. So, obviously for certain procedures, if we look at, meniscectomy, meniscus transplant, a lot of that stuff kind of decays with time. And so what we can say based on this article is that, it's pretty, it's pretty reproducible with time, right? And then, the other component of this was to look at, were they able to return to their sport? Was their hip something that prevented them from going back to their sport? And again, the main takeaway from that was that, about a quarter of the patients, all in all, had to stop sports because of their hip, essentially.
Right.
So,
but 50% of those patients reported that they no longer played the sports, and their hip was not the reason for discontinuing their sport.
Yeah, so, and that's and also if you look at, like, for instance, like their Tegner scores, scores in general went down, right? And the explanation for that were, they were in shape young athletes, and then they got kind of older, fatter, and had to work. So,
Okay.
well, it's true. You could take that across to any,
You can.
ACL study, shoulder instability study, any of these cartilage study. So like, any that I would say across the board is is a reason for things to kind of slow down with time, right?
Do you think that the lower tonus scores post-operatively were due to their lack of playing sports, or do you think it was due to their the hip arthroscopy having a positive effect on delaying arthritic changes in that involved hip?
I mean, you would hope that their tonus scores would would stabilize because of the because the arthroscopy. I mean, we know that, for instance, like Ben Dome had a study that came out last year. If your alpha angle is normal versus abnormal, meaning like you have a cam lesion or don't have a cam lesion, pre and post op, we know that your arthritis grade is lower at 10 years. So if Aaron and his friends did the surgery, it was Aaron and Bruce Levy. Those were the guys doing the surgeries. If they did the surgery right, then again, it should be kind of like what we're showing and what they're showing in this study is, it's durable in terms of actually like physical activity, clinical, outcome, clinical reported outcome, as well as, radiographic outcome, essentially, right? So we know it's kind of like, a little bit of like subjective versus objective, and
Mm-hmm.
so we know that subjectively, they were able to do the stuff they needed to do and be comfortable for the most part. And then objectively, if we take a picture of it, the picture kind of maintains.
It was interesting to see that only 4 patients at final follow-up needed a reoperation.
That's a very low rate because
Yes.
if you look at, for instance, like they cited Mang, Travis Mang, he's another friend of mine. He did kind of the long-term studies for Philippon, I think,
Right.
when he was a fellow. So he did some of the first 10 plus year hip arthroscopy follow-ups, and some of those studies they had like 30 to 40% reoperation rate.
Mm-hmm.
That being said, so this study I think was 2007 to 2014 was when or 2009, sorry, to 2014. So definitely, between I would say 2000 and 2010, the indications significantly tightened for hip arthroscopy, right? They
Right.
were doing, tonus grade 2, above 2. This was a pretty strict cutoff of 2 and below. Even 2 is pushing it because 2 is, you have narrowing, but technically a 2 is you have at least 1 millimeter of joint space, which if I did a hip arthroscopy on somebody with 1 millimeter of joint space, I don't think that patient would do too well. We're much more selective, and our selectivity has really, what we weed out and weed in,
Mm-hmm.
it's become much more restrictive because we know that certain patients are going to do well, certain patients are not going to do well.
33% of the patients in this cohort had iliopsoas lengthening. I don't see that anymore with the hip patients that come through our clinic. Are people still doing that? Or do you do that? I mean, tell us about that.
So I do maybe 1 or 2 iliopsoas lengthenings a year. Some of those are even on total hip patients that have iliopsoas impingement on their total hip.
Okay.
The only patient I would clinically at this point do iliopsoas lengthening is, so I don't even care if it's a snapping hip patient. So internal hip snapping, iliopsoas is snapping over the femoral head and neck. I don't even care if the patient has that. If that the only patient I care about having that is if it's a reliably painful symptom. And even on top of that, I will have the patient go for a specific iliopsoas bursal injection and see if that relieves their pain, particularly in the total hip patients. If that relieves their pain, it's no lie, I've had patients that are 5 years after a total hip replacement that have walked on a cane since their total hip replacement, have had painful snapping, and within a week of us releasing or lengthening their iliopsoas, their pain goes away. The flip side of that is these are young athletes. We don't want to weaken their hip flexion, right?
Okay.
And so it's it's, to me, it's really it's mostly fallen out of favor. Like, again, back in 2009, that was a totally different thing. When I was in fellowship, it was a very common thing for us to see and do.
Sure.
You know, it's kind of like the biceps of the hip, right? And so you see it, you know, you cut it, but I think it was kind of overdone, and I think there were some repercussions. Like, I also saw patients that, you know, were unable to do a straight leg raise for months after having an iliopsoas lengthening. So I think, you know, there's still a place for it. It's a very limited place, but I would be very selective about it at this point.
Certainly, you've taught me that the number one postoperative complication for anybody having a hip labral repair is iliopsoas tendinosis. It can be a nightmare. It can last a very long time, and you're not going to do a lengthening on that patient right away. That's for sure.
No, yeah, that's true.
When you do the lengthening, do you do a Z-plasty or do you do pie crusting?
So there's a couple described ways of doing it. So you can go outside the hip joint and you can go
Mhm.
down to the lesser trochanter,
Sure.
and you can do a complete tenotomy. That's not the way that I was taught or the way that I do it. The
Okay.
way that I do it is, um, if you're in the hip joint, if you go through the front of the joint capsule, at about 3 o'clock on the acetabular face, if you go
Mhm.
through the capsule at that point, your iliopsoas will be going right across the front of the hip joint. And when you cut it at that point, you're releasing the tendon fibers. The muscle fibers are still intact. So if you do it at that, which is the way that I would do it if I am doing it, then truly it is a lengthening. It's kind of like a tendo Achilles lengthening, where you're cutting it, but the muscle fibers are still intact, so you're just lengthening it. As
Okay.
opposed to, if I go and transect the tendon at the lesser trochanter, there's no tendon. You know, it's not attached anymore.
Right. Right. With the time we have left, let's talk about their rehab, postoperative rehab care, and let's talk about your postoperative rehab care. What are your precautions? What are your recommendations after you do a hip labral repair? And are you foot flat partial weight bearing? And do you begin therapy at 2 weeks, like the article showed? And do you let them jog and return to sports? Jog at 3 months and return to sports at 6 months? Well, that's kind of a fixed question since we just published the study, but together. So tell the audience
Yes.
first, please.
So the way that they treated these patients back in 2009 to 14, you know, I think that was a totally reasonable way of doing it. They did foot flat for 6 weeks. They did CPM. They did, yeah, kind of delayed physical therapy.
Mm-hmm.
The biggest thing for me nowadays, knowing what I know and having treated many of these patients at this point, is to get your hip moving, to get your weight back on it, you know, to safely progress your activity as fast as possible. And so for me, I've taken the CPM completely out of the equation. I used to use CPM at the very early part of my career. You know, people don't like CPM; they don't want to sit on it for four hours a day. You know, it's passive. They're not really kind of engaging themselves as they're doing it. Biggest thing for me, get them on a stationary bike the day after the surgery. Okay. And 10 or 15 minutes, light resistance. You know, I'll tell them some of the pearls that I say is, you know, raise the seat one or two. I like an upright bike, like a spin bike, as opposed to a recumbent bike, just because they're not having to flex their hip as much when they're more upright. I have them raise the seat maybe one or two notches above what they would normally do. And then the only other thing I sometimes tell them is, you know, if you are clipped in or you have stirrups, I would focus more on the push down than the pull up. The only problem I ever see with somebody on a stationary bike, and I've, you know, knock on wood, I've never had anybody have any injury or post-operative major problem on a stationary bike, even immediately after surgery, is, if they're really concentrating on pulling as opposed to pushing, they are activating that hip flexor a little bit more. So I just, you know, that circumduction motion over and over again, extremely beneficial for the hip. And it's like the CPM Plus. And obviously it's a lot more convenient, you know, if somebody has a Peloton or they have access to a gym or they can get the PT early, get them on that bike, because that's probably the most important thing for me, to activate those muscles in a safe way, and engage muscles, on both sides, and it's straight ahead. There's no torquing. Very, very, very beneficial exercise for me. And then I tell them they should get into physical therapy. I would say anywhere from 2 to 4 days after the surgery. I want to get them into PT right away. I do brace the patients. I do give them crutches, but the thing that I tell them is your weight bearing is tolerated, meaning you have the brace, you have the crutches. They're just there to help you walk. We will get you off the crutches and out of the brace as soon as possible. Some people that's a week, some people that's 2 weeks. I really don't want them an extended amount of time on crutches, because all that does is decondition them. I also am very strict about, for instance, if I see somebody come in on their first post-op visit and they're toe walking and they're hunched forward and they're holding their hip in flexion, I can almost guarantee that patient is going to be very, very uncomfortable. And so for me, the most important thing for them is to get their foot flat on the ground, heel to toe, and to have good posture. Because as soon as they start hunching forward, then their lower back hurts, their buttock hurts on that side. They're holding an isometric of their hip flexor. So that's a bad situation. They have a leg length inequality because they're holding their hip flex, their knee flex. The biggest thing is I correct their gait immediately, and then within a couple days they feel much better.
Mm-hmm.
Because for me, it's more about just kind of having them walk naturally. They're not going to have a lot of pain, particularly if they have crutches to support them if they need to. To me, it's very safe. I've never had anybody, re-tear their labrum, in that scenario. And then I'm very progressive about, advancing them. So my advancement timetable, I usually tell them, it's bike immediately. I'll let them do an elliptical, usually by 3 to 4 weeks. I have them do a slow interval flat jog program. I would say about 6 to 8 weeks. And then I have my ideal for them to return to sport is 3 to 4 months. Some people are able to do that. Some people it's 5 months. Well, the other thing I tell them is, you didn't tear your ACL, you didn't tear your Achilles. It shouldn't take you 6 to 12 months to go back to sports. And again, I think we've had as we're going to publish, or has already been accepted to be published.
Mm-hmm.
That's a very reliable algorithm in terms of getting people back with pretty much no risk to them getting back, in an early timetable.
Correct. Our average is about 5 months. Now we've had 10 people in that study that you're talking about that returned at 3 months, and then we had 5 people, I think, that returned at 4 months. So we're pushing the envelope, and none of those people had resurgeries or any kind of poor outcome scores on the Harris hip score or the ADL score. So. With that said, Rob, do you have any questions? Are there any questions from the audience before we wrap this up?
I have one quick one. So when it comes to like the bursa versus this tendinopathy, do you care to differentiate? Will you inject it, ultrasound it, or you don't? How you examine? Those are always tough.
You're talking about more about the glutes, or you're talking about the iliopsoas?
Iliopsoas we were talking about before. I just didn't like the idea.
For me, it's kind of a continuum. Sometimes on an MRI, you can see a lot of fluid in the actual tendon sheath, which is, I would say, more of the bursitis. But then other times you do see that tendinopathy, particularly like if you get a good MRI on a total hip and it's really, kind of grinding. We often see it grinding on the cup, on the acetabulum. Those are the patients. The bursitis alone, I would say less aggressive, and sometimes I will even send them for a steroid injection in the bursa. But if it really is a tendinopathy thing, and it's really, for instance, on a total hip, I'll be more aggressive about that. Most of the internal snapping that I see is not painful. They'll say it snaps, but sometimes they get relief from that. Sometimes the patient will say, I feel like something's tight or out of place in my hip, and all of a sudden I snap it, and then then it feels better. I think this is anecdotal, but I think if we do shave that cam down, that's less of a reason for them to snap. And if we decompress their hip and loosen up their hip, there's less of that tension on the iliopsoas kind of snapping across the front of the femoral head.
Thank you. Donis, is there questions? You're the young eyes, Donis.
While you're looking, I want to remind people that Dr. Galano will be speaking Friday, November 22nd at Lenoxville Hospital on 131 East 77th Street at the James A. Nicholas Sports Medicine Symposium on the athletic hip. Also speaking will be Dr. John Christopher Reddy and Mike Voigt. They'll be guest speakers, and so a bunch of Northwell Health physicians will be speaking at that conference also. It's a one-day conference. So look for flyers, look for any kind of announcements on that conference. Questions, Donis?
No, the one quick question was the seat height, and I know that the doc mentioned before 1 to 2 notches above their typical.
Yeah, and I think again the upright bike I actually prefer more than a recumbent bike. I know people a lot of times early rehab they're more slanted towards the recumbent bike, but I actually, for the patients that I've treated, like a spin upright bike is really for me it's the preferable configuration.
The one question I had personally, earlier you mentioned with the labral reconstructions, having them go from like a painful labrum to now, you mentioned having a labrum with no pain. Is that no pain because the nerve receptors have been removed? And if so, is there a concern for that, for like not having that perception anymore?
Yeah, I mean, so there's some thought in that, in like ACL, for instance, right, to preserve some of the fibers so you have some of the proprioception left in it. I haven't seen that be a problem with the labral reconstruction. I'm pretty much on the side of a circumferential labral reconstruction, meaning like a 360, not a 360 because it doesn't go it goes 270 around the socket, but a full labral reconstruction, because my problem with a segmental is you're still leaving some of that diseased labrum, right? The person, for whatever reason, whether it's a revision or re-tear or whatever, they've demonstrated that their labrum's not good, meaning it's, either poor quality tissue or repetitively painful. So I want to take that labrum and I want to throw it in the garbage, and I want to give them a brand new shiny labrum that is going to have the same function. And I have patients that I've done labral reconstructions on, 5 to 10 years ago, and I've gotten MRIs on them. It looks like a normal labrum. So, again, if we're looking at something like a meniscal allograft versus a labral reconstruction, I totally see where you're coming from on that, because that's a load bearing graft, right? A meniscal transplant is, it's this, right? It's like a disc replace, it's like you're going to put stress on that, right? Whereas with the labrum, because it's that suction cup seal, I think it's a lot more durable. All your surface area and weight bearing, we don't really change that with a labral reconstruction. I mean, we better distribute it, but it's not like the graft itself is seeing any significant, actually weight bearing. Again, if we're not doing it on like a dysplastic or something like that, which we wouldn't be. So it's just improving the biomechanics of your hip without any excessive stress on the dead person tissue that we put in your hip.
All right.
Thank you.
Well, thank you, Donis. Thank you, Rob. Dr. Galano, really appreciate having you, and we'll see you soon, all right?
Thank you. It was a pleasure doing this. I really appreciate it, guys.